so a medium level in terms of HIV need. And one other piece, too, that I don't have on the slide is I would say politically we are kind of middle of the road. I'm from Michigan, so some people had asked about strategies in a politically more challenging environment, and we're right in the middle. Next slide.
Good afternoon. I'm Amy Peterson, and I am with the STD program with the state of Michigan. And I, as you can see there, I have also a long history. I've been working for the state just about the same amount of time as Lori, but in a couple of different roles. In my earlier years with the state, I worked in the HIV prevention and intervention section and did a considerable amount of work as a trainer and then also as a prevention coordinator and prevention consultant. And then in 2007, I made the switch, and I came over to STD. And have been really happy to have the opportunity to expand my knowledge in that area. I am an associate member of NCSD, and I wanted to just plug that in there because they've been really helpful to me in my role in learning the areas of STD, and then I'm grateful to have this opportunity today to present with folks. And then lastly, I am a member of the Michigan Coalition for Adolescent Sexual Health, and you'll hear us talk a little bit about that as Lori and I proceed through the presentation today. And that is a statewide coalition that involves nonprofits, interested individuals, as well as state agencies, all committed to the same mission of advancing the area of adolescent sexual health. So just wanted to highlight some of those experiences. Next slide.
All right, so before we jump into the slide, I just wanted to preface the comments by saying that just in general in Michigan, we've been really fortunate to have really incredible partnerships over the years between health and education, and we couldn't have done half of what we do without those partnerships. It helps us to work better, work smarter, more efficiently, fewer gaps, the whole 9 yards. A lot of the concepts and examples that we're going to be sharing with you today are not going to be new to you. They're things that many of the things that you're already doing in your states or local jurisdictions. Maybe you'll get a new idea or something will spark for you. But honestly, so much of the things that we do in Michigan also, we've borrowed and gotten ideas from other states. So we hope that you do the same too. One other disclaimer is that as I'm talking, I do come from a state education agency point of view. And so while I think a lot of the ideas are relevant in terms of local, and obviously the FOA is for both state and locals, I'm going to be speaking from a state perspective. All right, so here's the colorful slide here, like color. But what I'm trying to show here is that within the state health agency, there are a lot of different units or programs that may have applicability to our work in adolescent sexual health. So a couple of the obvious partners that come to mind are HIV and STD programs or units or divisions. I don't know how different health departments are divided up. But other ones, there are many others, too, that are involved in the work of sexual health. I know in Michigan, I would say that a lot of our activities on partnerships focus with HIV and STD as well as with adolescent health, teen pregnancy prevention, and also family planning. But I thought it was helpful to kind of brainstorm and think about some of the less obvious partners as well because I think that they can be key players too. I know that sometimes in violence or intentional injury prevention programs, they can have efforts focused on violence prevention, also sexual violence prevention that overlap with our work. Substance use is another area that certainly overlaps. Another one that wasn't obvious but is worth thinking about, I think, is immunization in terms of their efforts working on both HPV and hepatitis B vaccines for adolescents. So I encourage you just to kind of keep the box wide open and think about many different partners and health agencies that contribute to and can be involved in our work. Okay. Amy, do you have anything to add?
No, that's great.
I'm just unmuted, so.
All right. So also in thinking about these different programs, you might want to think about what are some of the natural bridges that already exist. You know, who are the programs that you have overlap in terms of goals and objectives of your work? There's a lot of overlap in terms of education agency work in adolescent sexual health and STD, you know, especially given that the majority of people who are getting STDs are young people. So also think about who do you have established relationships with. But if you have people who are brand new to roles, don't worry about that either, because staff are constantly changing, and so you may be starting a brand new conversation with a new staff person, and that's fine as well.
Okay, Myra cannot get.
Okay, next slide.
And Dr. Class just
Oh, Phil? I thought you had Monday.
So one of the things that we did in Michigan that was really helpful was we created a grid document that is really, I guess, an inventory.
Are you trying to get everybody?
What programs were already, initiatives were already involved in partnerships with.
So it actually, I'm getting kind of worried. I've asked them all to.
I think that there's someone's phone is not muted, and so we're getting a little feedback. Great. So we found that having a grid like this, and I encourage you to do similar things in your own states or local jurisdictions, to take a look at various categorical programs which are lined up in column format, and then different ways that you might be partnering on issues pertaining to adolescent sexual health. So we kind of brainstormed some big categories of types of ways that we might be partnering, like conferences, committees, grant planning and implementation, trainings, curriculum, policy guidelines, clinical services, data and surveillance, and that's how we structured this document. My computer is now going away, so I'm not going to be looking at the computer anymore and just looking at my printed out slides. So don't pay attention to the checks here because that's not important, but just I think the process of doing an inventory and looking at the kinds of ways that you might be collaborating is the most helpful thing to do here. Note also this isn't an all-exhaustive list. You may think of a whole other categories on the left-hand side that are valuable to look at as well. But this helps you look at what you are already doing, perhaps what you could be doing, and helps you to kind of chart a course of action for the future. Next slide. So now we're going to move into talking about a few examples of how the Department of Education has collaborated with the Department of Public Health, called Community Health in Michigan. And this is not an all-exhaustive list of different ways that we partner, but just a few examples. One thing to keep in mind is that we aren't sharing these examples thinking, you are going to do exactly the same thing in your state or local jurisdiction, but maybe it might spark some ideas again about kinds of collaborations that you hadn't thought might be possible that can be really valuable. So the first partnership we're going to talk about is a project where a number of years ago we talked with epidemiologists within our state health department about looking at the data that they had on chlamydia and gonorrhea and seeing if we could dovetail that data with school district information to get some information about chlamydia and gonorrhea within the geographical boundaries of school districts. And so what we learned was that the chlamydia and gonorrhea cases, each young person or each person who's diagnosed has an X and a Y coordinate, so they can literally be graphed according to where they live. And we superimposed the geographical boundaries of school districts on 15 to 18-year-olds who had chlamydia and gonorrhea. And then we looked at also the number of students in high schools in those school districts. And from those pieces of information, we created rates by school districts for chlamydia and gonorrhea. Now, we knew that this wasn't going to be exactly accurate in the sense that you may have people who live at a certain address and don't go to that local school district. You may have people who are in charter schools or public school academies who their school district is not defined by geographical boundaries. But nevertheless, it gave us a sense about higher need and lower need areas. And then we were able to share that information with school districts, and they found it really helpful in terms of thinking about what kinds of programming to pursue. If they had a high chlamydia rates or gonorrhea rates in their area, like it might not make sense for them to have an abstinence-only sex education curriculum, for example. So that was one partnership that we found to be really helpful and interesting, although probably not possible if you're in a jurisdiction where you don't have an epidemiologist who has that kind of time or access to that kind of information. And we also have a really great data system on the education side that gave us easy access to the geocoding, the boundaries of school districts, as well as the student counts for students in grades 9 through 12. So we can move on to the second example.
Thanks, Lori. So the second example that's on the slide here talks about the development of a sample memorandum of agreement for school-wide STD screening. And this was a partnership, again, it was between NCSD in terms of their providing technical assistance to us. But ultimately the MOA was between the health department, the STD program, the school district where a school-wide screening would occur, and then a medical provider, whoever was going to be the medical provider to the project. And we came together, and Lori's role was really as an expert consultant, given her background and understanding of schools and school districts, kind of the norms and expectations, and also brought in heavily the perspective of parents and the importance of involving parents and notifying parents. And so if you want to go ahead and go to the next slide, I'll talk a little bit more about the two perspectives. Thanks. So as we were going through the process of developing this MOA, and again that process was being facilitated by NCSD, what we saw was that we oftentimes had kind of differing opinions about what level of detail and what were some of the most important things to have in the sample MOA that we would be then utilizing as we went ahead and did school-wide screening in different jurisdictions around the state. And it was interesting, if you see here on the two kind of columns, from the STD program perspective and from the perspective that I was bringing into it, we were really utilizing models that had been utilized in other parts of the country. We understood that it was important to notify parents that the event was going to occur and that they could opt out their child if they chose to. But we really were trying to stay under the radar. And we believe in a process in that event of really providing information on a need-to-know basis, because we have had experiences where when we try to get too many people involved, of course, the more people who are involved, the more opportunity you have for people to really kind of throw a wrench in it. And so I was coming from that perspective of provide information on a need-to-know basis. And on the other side, Lori, coming from the state education angle again, was really encouraging us in making sure, make sure that parents are notified and that they're involved, make sure that the school understands what's in this process for them, that it's not just about the screening and the identification of disease, but that there has to be a benefit for the school also for them to want to participate as a partner. And so I think that ultimately the product that we came up with, which is it's in draft form, we're kind of pushing it up through the system here in Michigan, but no matter what, even if we how we utilize it in the future or if it gets tweaked just a little bit more, just that collaborative process of having those various perspectives come to the table, I think helps us have a better product and a product that's more balanced to consider the perspectives of all the partners. Next slide, please.
So another example of collaboration is in the area of review panels, and I know that that has been a requirement of the CDC-Cooperative Agreement and continues to be a requirement in the upcoming cooperative agreement that we have a review panel. And I know that on the health side that they also have a requirement within their HIV program for the health departments to have similar review panels. And so that's a very logical partnership where I have served on their review panel before, and I always make sure that I have people representing some of those bubbles on our review panel. So someone representing HIV, someone representing STD, adolescent health, and that has been really, really helpful because we have parents and we have teachers, classroom teachers and administrators and other folks on the review panel, but to have someone from the State Department of Health who has that content expertise and background is vital.
Excellent. And the next example that you see there talking about donation of staff time for a shared mission, and this goes back to the coalition that I spoke of in my introduction. The Michigan Coalition for Adolescent Sexual Health is a body that came together to further the mission and ultimately to develop a Michigan sexual health plan. And in that process, the ways that the health department and Department of Education were just part of the larger collaboration, but together we did use our expertise and our access to data to develop presentations that were then conducted around the state. We did 6 community conversations around the state where local data was presented and focus groups were held with individuals about their perspectives on adolescent sexual health, what's important, what needs to be included, what sensibilities need to be considered. And so we also collaborated in actually conducting those meetings. And then in the next stage, we became part of a small subcommittee that actually drafted Michigan's Adolescent Sexual Health Plan. And I think that both of us coming from a state level, we have considerable experience with developing guidelines, documents, and larger written pieces of work that ultimately we were able to bring a lot of that experience to the table and help both of us further our shared mission of addressing adolescent sexual health.
Great. And then the last example we have here is that Michigan is one of the few states in the country that does develop our own model curriculum. We have model health education curriculum, K-12, and that includes sexual health-focused curriculum in upper elementary and middle and high school. And we always make sure that we have people from public health who are on the review committee, but also even more in depth than that, like we take the content lessons. If we have several HIV or STD content lessons, or we have a content lesson focused on family planning methods, we make sure that we run those entire lessons by the leads in those areas in the state health department to make sure that we have medically accurate information. We're using the current terminology. We know that terminology in the arena of HIV can change often, and so we try to make sure that we are current with all of that. And we couldn't do that just on the education side because we don't have that level of expertise. So moving to the next slide. So putting it all together, win-win partnerships. Why does education need health? Well, for lots of reasons. And I already talked about some of these, but to make sure that what we're doing is medically accurate and consistent with the latest that we know about best practices, whether it be in HIV prevention or STD or any of those areas. Public health, I think fortunately and unfortunately, but often unfortunately, has these categorical divisions. And so often we need to kind of seek people and input from multiple categorical areas. But that helps to make sure that the products and the things that we do are better. They are the ones who have really sophisticated surveillance and data systems. And so while for many states, for example, the Youth Risk Behavior Survey comes out of the State Department of Education, there's a parallel surveillance system for adults, the BRFS, that comes out of public health, and lots of other surveillance systems as well and data systems. And so constantly I'm talking to people in public health saying, can you help me to get this STD data sliced in this way or this geographical level, and I couldn't do without them. Public health has expertise in helping people access services, and services is the new piece that's, access to services is really emphasized in this FOA. And, they have expertise in reaching high-need populations, and with less resources, that's the focus of our work, is how can we impact the greatest number of people with not a lot of resources, so we need to drill down and really focus on those populations at greatest need. So we look to the health department for help in this area. And also their constituency is going to be, health departments and community-based organizations primarily. Those aren't our constituencies in education, and so they have entree with those organizations that we don't have in education. All right, next slide.
Thanks, Lori. And so the flip side of that coin that Lori was just outlining is, why does health need education? And so these are just a couple of examples, and again, you'll see that they're very parallel. First of all, as a health department, as she said, our partners are primarily health departments or clinics as opposed to schools. And so if we want entree or we want to influence what's happening in the school or to reach those school-age kids, the Department of Education is key to that. They allow us access at some level, or at least our important health messages, to have access to a large adolescent population. And they provide us with expertise in developmental and age appropriateness when it comes to, oftentimes we may fund a community-based organization, or we may be partnering with a health department that wants to develop some type of educational messaging, either web-based content or brochures, and we can run that past or use Lori as a liaison to getting expertise to review that. And then also, there are requirements in our public health grants, for instance, as she spoke about, review panels that are requirements for this partnership but also benefit us. And then the next one, talking about balancing CDC's targeted HIV prevention funding. The prevention funding that comes from CDC primarily to the states is intended to be very targeted to those at highest risk. And over time, that has become more and more restrictive in kind of where can these limited resources be utilized and with what populations. And currently, the highest ranking populations are men who have sex with men or persons who are living with HIV already. And so that has to be balanced when you're trying to do HIV prevention at a statewide level with other resources and other opportunities to educate populations. And again, the work that MDE does and through the DASH office allows us to reach a broader population in terms of the adolescent population, but with more of just the basic education messages that are intended in our outline, for instance, in the National HIV/AIDS Strategy, where it talks about highly targeted services, but then it also talks about the need to educate all Americans about the threat of HIV and how to prevent it. And then lastly, here in Michigan, we're fortunate because one of the areas that our DASH program has chosen to focus on and that they have really built amazing expertise in is working with lesbian, gay, bisexual, transgender, and questioning youth. And that work is truly primary prevention for HIV and STDs, because helping those individuals to feel healthy and happy in their skin and to be able to reach out and receive prevention messages is going to be key to their sexual health in the long run. So those are some ways that health needs education. Next slide, please.
So basically there are lots of kinds of partnerships, and partnerships range in terms of the depth of those partnerships. And so often we are working with people and doing kind of sharing information or getting or giving input. And so that's something that we do a lot, and that's not as deep. We've all had examples where we, send an email to another person's listserv and they send it out, or we ask a committee to give us guidance on a project. So those are the examples of kind of not as deep partnerships. And then as we go deeper, there may be joint planning involved. For example, in Michigan, we are about to put on a conference just for parents on adolescent sexual health, and it's co-sponsored by the health and education agencies. So that's been a joint planning endeavor. And then as we go deeper, we talk about sharing resources, and those resources could be fiscal or they could be human resources. So we have a state-level youth advisory council, and historically multiple units, both within public health and also education, have contributed money to that state-level youth advisory council. And so that would be an example of sharing resources in our partnerships. And then probably at the deepest level has to do with sharing staff. We have several consultants who, two examples, our state nurse consultant and also our mental health consultant, who are literally shared with both public health and education agencies. So they have offices both in our unit in education and then over also in the adolescent unit in public health. And so that is a much deeper level of partnership involved there. Next slide.
Okay, so what we're highlighting here are just some lessons learned about effective partnerships. And the first one cannot be said loud enough or often enough, and that is that it really is all about relationships. Many of us have had that experience where we reach out to a partner maybe kind of blindly because they're in the right position, and the reality is that sometimes that goes really well and we are able to go forward and have a great working relationship, but sometimes also the best intentions are that you've developed something together, but then it's kind of not a priority for the other person or the other entity, and so then it falls flat or it doesn't go anywhere. And so I think what we've learned here in Michigan is that developing the relationships or reaching out to people that you already have relationships with and figuring out how can you partner together, how can you create things that synergistically will be larger than either of your programs could be alone is really key. And that if you have a relationship first, some level of understanding that person, understanding their work and their commitment to that work, then it's more likely that you will, both sides of that equation will truly take that plan and go forward with it. Another key to effective partnerships is the importance of truly documenting and institutionalizing those relationships so that if you have a change in staff or over the course of time, sometimes balls get dropped, we all have that experience, that you have something in writing that you can go back to and bring that other office or department back to as well. And so in this application, I know that it requires that an MOU, MOA is developed between the state and education, or excuse me, the health and education entities. But there's other ways also to, outside of this FOA, to be able to actually, document that experience and that history. Lori uses a great example in that she's kind of the queen of the two-pagers, and that she writes a two-page kind of outline of a lot of different initiatives that she's part of. And what that does is it allows her to use those as almost a marketing tool, and it also is a document that can be shared with those partners that makes the partners feel really good, like, yeah, together we did that. And so those two-pagers I think are great and have a number of different, meet a number of different needs. But that doesn't mean that that's the only way that those things could be documented. It may be that you write newsletter articles or you send out a quick email to a group of partners and say, this is what we've been doing, just wanted to thank folks and talk about what we've achieved. And you may, but document that stuff and keep that and keep it as a file, either electronically or paper-wise, that you can utilize and revert back to and go back to at times when you need to. Because that thing about documenting it, again, is good for the relationship. It fosters the relationship, but it also can be particularly key if you have a time where maybe you have staff who leaves and you have new staff that you have to orient and have to explain kind of what your traditional partnerships have been and what the commitments are that have already been made going forward. Next slide.
So in Michigan, we found that relationships are invaluable, but they also need lots of tender, loving care to make them grow and thrive. And we've learned the hard way sometimes that relationships and process with the key stakeholders are even more important sometimes than the products. And what I found is that if you have the strong relationship, you can ask for almost anything. But to build those relationships and nurture them, what I found is that regular communications really help. And more, when those communications can be face-to-face, I find that's even better, just because you lose a lot in the translation in email, and there's something that's most powerful about meeting face-to-face when it's possible. We're a big geographic state, so we recognize that things are definitely not always possible, but we strive for that when possible. Also, in some of the interagency groups, I think really combining work and fun, just so that you enjoy being together, and just a balance of give and get. So it's not always one party that's getting or one party that's giving, but just something that everyone is getting something out of. So just a few lessons learned. All right, next slide. One final piece, too, that I wanted to mention is that we've found it really valuable in Michigan to have an umbrella organization focused on adolescent sexual health that's not within the boundaries of state government. I think that maybe 20 or 25 states have a similar organization, and sometimes it's not a 501c3, sometimes it's a coalition. But it's helpful, I think, just because, in health departments, there is this categorical breakdown, in terms of HIV and STD, teen pregnancy, adolescent health, often within two different, whole boxes on the organizational chart. And so we found it helpful to have this Michigan Organization on Adolescent Sexual Health. They really have more latitude than government in a lot of ways. Also, they can serve as a fiscal agent. So again, like that example when we were talking about the state-level youth advisory council, we could all give money to MOASH, and then they could lead the project and disseminate the money as needed as needed. And also, non-governmental agencies are able to apply for and receive funding that we're not eligible for. So just put in a plug for those third-party organizations.
Okay. Great, thank you. Thank you, Lori and Amy. I'm going to turn it over to Elizabeth Howler now to talk about the FOA requirements.
Great, thank you so much. So many of you may have heard a lot of what I'm going to say today, and page numbers may vary based on how your document downloaded from grants.gov. Some of the things that we're looking for in the FOA are identified on pages 20 and 31, such as senior organizational leaders at both agencies to provide leadership and oversight. We want to know who they are at both of the agencies that's going to help implement the required activities that are seen under the announcement. Second, we're talking about the articulating a commitment to coordinate program activities and leverage funding. It doesn't need to be cash. It can be staffing. It can be resources. It can be collaboration. It's however you define leverage. It's however you define coordination. But between ed and health, we're looking for that commitment up front at the time of application that you will coordinate your program activities to make sure that you can achieve the most out of this FOA. Identify the designated liaison within the education and health agencies who will serve as the technical expert, the person who will be the person that answers all the questions and knows all the details about what's being done in both agencies. And this is for the management and coordination of cross-agency activities. They're the go-to person. They could be the coordinator, they could be the supervisor of the coordinator, they could be somebody else. The language is so different across the country that within this we tried to provide language that we felt could be generalizable across the country. And finally, the activities that we list in the FOA and that we're discussing today are not limited to what can be provided. They're simply examples of things that we do expect. And on page 31, you'll see more of those outlined under the bullet. Some of those in which Lori and Amy discussed on the presentation today, and others that we discussed during our calls last week. And
great.
Yep.
Thank you, Elizabeth.
You're welcome.
And thank you, everyone who are sending in questions via the chat box. We will get to those questions at the end of the presentation, but we will try and address every single one of them. Many of you already have established relationships between your health and education agencies, and others partner on a regular basis without any formalized MOU. So after reviewing the specific requirements in the FOA, we suggest that you conduct an internal brainstorm within your agency to see how best you might partner with the health agency. Figure out who would be the best contact for that MOU or MOA, and who would be involved continually throughout the 5-year project. Connect with them regarding the FOA, explaining the requirements, the benefits of partnering, and the benefits of formalizing the partnership, such as continued funding through the CDC or ability to continue an already established project, and determine the steps and timeline for the MOU. So who needs to be involved, who and how does it get reviewed and signed off by, and what is the time needed by both parties, both agencies, for this review process. Some general guidelines for MOUs are to identify the key people involved, specifically for this FOA. Elizabeth just outlined who some of those key people are, so senior leadership and a liaison in each department. You want to keep the MOU simple and avoid the use of jargon. If you're using acronyms, to be sure to explain what that acronym stands for. Keeping it simple makes sure that there's little confusion on the responsibilities and duties of each party. You also want to be realistic in your expectations for both departments. Make sure it's something you feel you can do and is within your control and your abilities. Lay out what each party is responsible for, and if there are responsibilities that you are both responsible for. You want to identify when the agreement will be reviewed. Is it reviewed annually, the end of a project, at the end of the grant? And what can each party do if they need to make a change in this document? So is there advance notice needed? Does it need to be provided in writing? And also, how does somebody get out of the agreement? So for example, if funding is stopped, if that was to put in, if you place that in the MOU saying that if funding is no longer available, then this agreement is kind of null and void. And most importantly, understanding the timeline, again, for a final signature to happen, making sure the right people are in town when they need to be in town based on your deadline. Are there certain levels that need to approve the document before going forward? This can be something that can really hold up the process of getting the MOU or MOA finalized. Some items to consider that we've already discussed, obviously dates and the parties in the agreement, which departments are involved. What are you trying to do with this MOU? So what is the overall goal? What's the overall purpose of having this agreement between the two departments? Outlining the specific responsibilities of each department. This would be one time to be very specific and not too broad. Confidentiality, liability, termination clauses, and amendment clauses are not necessarily required for the CDC FOA and may not be required of every MOU or MOA that you do or that you create. That's really dependent on what your project is and the requirements of your agency for signing on to MOUs or MOAs. And of course, you want to include the duration of the agreement and have the right people signing. Usually it is a executive director or a CEO, depending on what type of organization you're from. But definitely check with your higher-ups to determine who needs to sign an MOU. For this MOU for the DASH funding announcement, suggest maybe putting in there contingent upon funding, because you won't know, of course, as everyone signs on, you won't know about funding until after the MOU is signed. Here are some sample MOUs or MOAs. We have one from Advocates for Youth, another from ETR, which is around school-based STD screening, and then one from New York City, which is about public school programming related to HIV, STD, and teen pregnancy prevention. Those you'll be able to follow the links. We'll all be sending out the PowerPoint and uploading it to NCSD's website, so you'll be able to click on those and go to find those examples. Some other resources, in case you're looking for possible people within the state health agency to partner with, or maybe you're not sure who the STD program director is, or AIDS director, or maternal and child health, here are a few links. One from NCSD, one from NASDAD, and one from HRSA, which names your state's health agency representatives for those different topic areas. There might be others that you reach out to that Lori mentioned as well, but I do not have links for those. And before we wrap up and take questions, just wanted to give another resource out to people joining the call, and that would be joining NCSD. So you all are welcome to join as associate members, and it's a great opportunity to learn from other colleagues that are working in sexual health, not only with youth, but with adults as well. And it's available and free. You are encouraged to take advantage of this, and you can click on the membership forms to find out more and to chat with our membership director, Kelly Mayer, as well. We also have an upcoming webinar at the end of March that you might be interested in about sustainability and what to do kind of when funding is running low or running out, and what parts of your programs you can sustain without continued funding. So now I'd like to turn it over to some of the questions that we have. Let me go ahead and get started with one. Elizabeth, I think this one would be for you. Lori Stern wants to know, we have a long-standing MOU that covers coordinated school health inclusive of HIV, STD, teen pregnancy prevention. Will this still be an acceptable format given the more specific requirement in this announcement?
Yes, it will. We've actually had those conversations with the consolidated application folks. They had their call, I believe it was yesterday, regarding their FOA that was released last week. And one of the things that we've talked intra-agency about is just that. And so if you are already going to be doing an MOU for the HIV program, if you're going to be doing an MOU for the consolidated application, it's okay to combine those. Just make sure that the information is specifically spelled out for HIV to meet the needs of the FOA requirements, and also for the consolidated application to meet the requirements there.
Great, thank you. There's another question about sharing sample MOUs or slides of the website, and yes, of the webinar, and those will be available on NCSD's website, hopefully tomorrow, and you will receive a link to those resources. Another question, our MOU is typically a broader statement of our respective commitments, and once funded, do an interagency agreement that is very specific. Is there a way to work within that structure with this FOA?
Based on the FOA requirements, you're going to need to meet those 3 main bullets or 4 main bullets are outlined on page 31. That's what you really need to make sure that you meet. And then if you need to go deeper, you can do that, and if you need to modify that after funding, you can do that as well.
Another question, I think, Liz, is also for you. Can the MOU be between multiple divisions within the health department? For example, can the MOU be with both the STD division and the MCH division? I think we might have lost Liz Howler.
This is Lori. I can just say, like, for us, our adolescent health is a different box on the chart than HIV and STD, and so we are going to go higher than both those boxes to a box that encompasses both boxes. So I think that, when you're working with 2 different entities within the health department, it just helps to go higher up in terms of who signs the letter to make sure that all those programs are covered.
Thanks, Lori. We have a couple more questions that are specifically related to the MOU and kind of requirements around the MOU. And since Elizabeth Haller isn't on the call right now, what I will do is I will forward those questions to her along with your name and contact information so that she can get back to you about those specific requirements. If you have any questions that are not related to the specific requirements associated with the MOU, please take a moment and put those in the chat box. We will include the question and answers to all of you, include that on the NCSD website. It looks like we have Liz back on, so I'm going to go ahead and unmute her to answer a couple of those questions. Again, the webinar will be posted on our website. We did miss the first 2 or 3 minutes, unfortunately, on the recording, but the majority of the webinar did make it to the whole recording. Liz, are you unmuted now? Liz, I think we have you back on, do we?
Can you hear me now?
Yes, yes.
Excellent. I'm so sorry. We had kids coming home from school all at the same time. I'm so sorry, and I pushed the wrong button.
No problem.
Can you go ahead and repeat those questions?
Of course. Let's see. One was kind of a follow-up to one that you previously answered. So the question is, can we do the minimum MOU now and then alter as necessary after? All right, well, I believe we're still having some technical difficulties. So what we'll do is we'll go ahead and forward these questions to Liz and also include a list of them on NCSD's website that will be uploaded tomorrow. So again, thank you so much. I want to thank you to all of our presenters, to Amy and Lori and Elizabeth Howler from CDC. And thank you so much. And please be sure to fill out our evaluation. You can follow the link on the slide, or it should automatically take you there after you exit the webinar. So again, thank you so much, and I appreciate it. Yes?
I'm here. I'm sorry, we're having terrible difficulties. You need to meet the requirements that are outlined in the FOA, and so it's a local decision whether you think that your current MOU meets those requirements or not. We're not going to be able to judge and give you input or feedback on whether you think if we think you meet those requirements. So you guys really have to make that decision for yourself before you submit that MOU.
Great, thank you. We had a couple of questions that were about the FOA, and if you could just go ahead and send those questions that are outside the MOU to -FOA@cdc.gov. They will go ahead and respond to your question.
Yes. Please. Thank you, Becky. And we have about 140 FAQs that will be posted, we hope, early next week on the FOA website.
Great. Thank you. So thank you, everyone. We will go ahead and make sure your questions are answered following the webinar, and we will post those. And I hope everyone has a great day.
Thank you. Please stand by.